Ohio River Valley fever, a classic case of disseminated histoplasmosis in an immunocompromised patient. Histoplasmosis is an opportunistic infection caused by the dimorphic fungus Histoplasma capsulatum. This fungus is endemic to the US states bordering the Ohio and Mississippi rivers and other parts of the world, including southern and East Africa, as well as parts of South and Southeast Asia. Commonly associated with soil rich in organic matter like guano or bird droppings, the infection is asymptomatic in most individuals who have been exposed to it. When symptomatic, it is primarily a pulmonary infection. However, it can present as a disseminated syndrome involving multiple organ systems, including the gastrointestinal, central nervous system, adrenal glands, and skin. Untreated disseminated histoplasmosis is rapidly fatal, with a mortality rate of up to 90%. A 30-year-old male presented to the ED with a 2-week history of high-grade fever, chills, dry cough, dyspnea, and watery diarrhea. He had been diagnosed with HIV at a free clinic 7 months prior. He was established with a PCP who prescribed HART, but he did not take it and never followed up until he developed these symptoms. He made an appointment with his PCP, who sent him to the ED immediately. On presentation, he was febrile with a temperature of 38.8 degrees Celsius, tachycardic with heart rate 114 beats per minute, and hypotensive with a blood pressure reading of 80 over 50 millimeters of mercury. The patient was also saturating in the low 90%, requiring 2 to 3 liters of supplemental oxygen via nasal cannula. Patient reported a history of immigration from Mexico to the US as a child. He had also been briefly incarcerated a few years ago and had never been tested for TB. Interestingly, he was currently employed cleaning grain silos in cargo trains in a yard in rural northeastern Illinois. On further questioning, he confirmed there had been some construction work in his area, as well as recent rainy weather and humidity. Within the first hour of presentation, the patient received the sepsis bundle, including IV fluid boluses and empiric antibiotics. Labs were significant for mild anemia, relative neutrophilia, and mildly elevated bilirubin. CD4 count on presentation was 124. CD thorax showed diffuse miliary opacities. Given the patient's history, differential of tuberculosis as well as disseminated fungal disease were considered and relevant testing was ordered. He was placed in isolation and started on empiric antibiotics, IV vancomycin and IV Zosyn for sepsis. His quantiferon test was eventually negative, and so was his first AFP sputum culture. Histoplasma and blastomyces tests were both positive, with the histoplasma antigen titer above the limit of quantification. Due to the endemicity of blastomycosis in this geographical region, it was still on the differential and co-infection was also considered. BAL was offered, but the patient refused. Meanwhile, his diarrhea, which was originally assumed to be a manifestation of GI involvement due to fungal disease, was diagnosed to be Campylobacter, for which he was started on azithromycin. Testing for other opportunistic infections like pneumocystis pneumonia, cryptococcosis, aspergillosis were all negative. The patient was started on liposomal amphotericin B and HART. Rapid improvement of his symptoms was seen over the next few days. However, his renal function started to decline because of amphotericin B, and he was switched to oral itraconazole on day 5. The patient eventually left the hospital against medical advice, despite being explained the risks of improper treatment. His primary care provider informed us that he had been seeing him in clinic and is now adherent with all his medications.